Gracias para la invitación. Yo hablo español un poquito, pero yo pienso que no también bien bastante para presentar en español. So, la presentación será en inglés. So, let's discuss about Mrs. Payne. Mrs. Payne presents to you in your labor and delivery ward. She's 26 weeks and she has abdominal cramps for 4 hours. And her prenatal care has up to date been unremarkable. The physical exam is unremarkable, and on the vaginal exam you find that the cervix is long, closed, and posterior. On the monitor, on the cardiotocogram, it shows that she has contractions every 3 minutes, and that the fetal heart is reassuring. Next exam, an hour later, the cervix is essentially unchanged. The CBC is normal, the complete blood count. Urine analysis is normal as well. No leukocyte, no evidence of infection. So what's your diagnosis and management? I'm not asking you to answer right now. And let's talk about another scenario here. You have Mrs. Lucky Thrice. She's 40 years old and she's carrying triplets. Triplets. And she complains of pelvic pressure at 27 weeks. And she surprisingly had a fairly uneventful prenatal care for triplets. And at 3 amnios, totally within normal limits, normal. And the cervix is, however, 3 centimeters, 100% effaced at +1 station of a presenting triplet rather. So all you notice, which is a bit unusual, is polyhydramnios of triplet A. So what's your diagnosis and what's your management? Which is essentially the topic of my presentation today, preterm labor and the role of tocolysis. Preterm delivery, as you know, is, at least in the state, the leading cause of infant mortality and morbidity. It has increased from 8 to 11.8% in the US. In terms of burden in our society, and 4.6% of fetuses are born prior to 34 weeks, either from spontaneous preterm labor as a result of preterm PROM, premature rupture of the membranes, which is about equal 40%, and 20% are born prior to 34 weeks because there's a medical indication, either maternal or fetal, to deliver the baby. Etiologies, very often as a risk factor, you have a history of preterm birth. Other etiologies can be due to an infection. Race certainly plays a role. We don't exactly know why and how, but it does. It's been shown that African Americans, even controlling from all of the factors, have a higher incidence of preterm birth. Leading uterine anomaly, obviously multiple gestation, poor prenatal care, substance abuse, cocaine notoriously will often trigger preterm labor, low socioeconomic status, low BMI, and other medical complications. I won't go through this very complicated slides because I think although we know how labor is triggered in sheep and other animal models, in human it's still a mystery to us of what triggered term labor, so even less preterm labor. So it's certainly an interaction between many hormones and enzymes. All we can say briefly is that sometimes a systemic infection will produce the release of cytokines.
Aumentamos la imagen aquí con este para,
okay, sí.
Para que hay partes que no se ven.
Sí.
Listo, gracias.
Bueno, es mejor. Ultimately releasing an increase in intracellular calcium and ultimately leading to uterine contraction and cervical dilatation. So, I could talk about predicting preterm birth, tocolysis, which is essentially tocolysis, stopping labor. And I'm going to briefly talk about the prevention of preterm delivery. Predicting preterm birth, I think there's enough studies out there to show that home uterine monitoring has not been very helpful or very promising to predict preterm delivery, nor has salivary estriol. However, oncofetal fibronectin is useful in some cases, as well as cervical length in the setting of acute preterm labor. Oncofetal fibronectin, very briefly, if you do a swab of the cervical vaginal junction between 24 and 34 weeks, if the swab comes back positive, that is at more than 15 nanograms per deciliter, you do have an instance of preterm delivery. However, it has a poor sensitivity, that is, and a poor specificity and a poor positive predictive value, meaning that most patients who test positive, in fact, will not deliver preterm or within 2 weeks. What's helpful, I think, in this test that we use once in a while at Cornell is in its negative predictive value. If the test is negative, you can be pretty reassuring that 99% of the patients will not deliver anytime soon. So that's helpful in that respect. So there's been a slew of tocolytics that have been used over the years. I don't know if some of you were in the times of, I should add alcohol in there, but alcohol was used as one of the first methods to tocolyze patients. You have a ward of drunk patients on the floor in preterm labor, so you don't know if they actually didn't feel the contractions because they were too drunk, or if it actually was effective. I think, but it's been shown in studies that it doesn't make any difference in delaying delivery ultimately. There's magnesium sulfate, which is, in our country anyway, in the United States, the most commonly used tocolytics. Ritodrine was used in the past. It's actually the only FDA-approved drug in the States to stop preterm labor. However, it's been taken off the market, so not very helpful. The other medications are used sometimes, but very often off-label. That is, they use for other indications, but if we use them for tocolysis, it's off-label, such as magnesium sulfate. I cannot say much about atosiban because it's not available in the States, but I know it's used very much in Europe, and I don't know if it's used in South America. I'll be more than happy to welcome your comments and input about it. Hydration and bed rest. Let's talk about something which I cannot teach my interns and residents not to do. Keep telling them that hydration and bed rest does not work at all. Unless a patient is grossly dehydrated, giving a liter of fluid will not help. It's been shown in many studies. And bed rest is helpful, in my mind, only for one thing, which is the management of hypertensive disorders. So there's no role for bed rest in terms of managing preterm labor. So very often we have studies that look at different goals of tocolysis. What do you want to achieve when you use a tocolytic? Do you want to decrease contractions? Do you want to arrest progressive cervical dilatation? Do you want to prolong the pregnancy by 24, 48 hours or 1 week? Do you want to achieve a term delivery? So I would argue that actually none of the above. What I want is I want to decrease the perinatal mortality and morbidity, because if I haven't achieved if I've achieved the first few items without changing my ultimate outcome, I haven't achieved anything at all. And what should not be involved in the use of tocolysis, in my opinion, is the physician's anxiety and using tocolytics for medical legal concerns. So magnesium sulfate. Magnesium sulfate has been shown to be a splendid medication to prevent seizures in severe preeclamptics and HELLP syndrome. It works very well in that respect. But some people notice that when you give magnesium sulfate, the contraction seems to arrest. So in 1977 came a paper from New York, I believe, showing that maybe we could use magnesium sulfate to arrest preterm labor. It makes sense in a way because at the level of the myometrium, it competes with calcium. It decreases intracellular free calcium, decreases the actin-myosin interaction, and inhibits the myometrial contractility at levels between 5 and 8 milligrams per liter. And then, of course, as I said, as a level of the central nervous system, it decreased the acetylcholine and sensitivity at the motor end plate, therefore decreasing the threshold to cause a seizure, which is very useful in eclamptic patients. But in terms of trial comparing magnesium sulfate to placebo, it's very disappointing to see that in fact there are only 3. And they're rather old, and I think one of the most important discoveries that has been made to prevent morbidity associated with preterm labor is the use of steroids. And in those days, even up to 1993, steroids were not widely used yet in patients at risk of preterm labor. So in these studies, the steroids were not used systematically. And very often, you have a lot of studies compare magnesium sulfate to other tocolytics, but I think the truth is to see if a medication works is to compare it to placebo. And the outcomes measure are often unclear. Sometimes the outcomes measure will be decrease of contractions. So that's not very helpful to me because ultimately, as I said, what I want is an improvement in my perinatal outcome and my fetal survival, my neonatal survival. Cotton published in 1984 the first prospective randomized controlled trial compared magnesium sulfate to placebo to terbutaline in fetuses of gestational age between 26 and 34 weeks. His diagnosis of preterm labor was 3 contractions in 10 minutes and any of the following changes on serial exams: 2 centimeters and less than 5, effacement more than 80%, and SROM. And some people will argue that rupture of the membranes is a completely different diagnosis than spontaneous preterm labor. But nevertheless, they included these patients in that study. There were 51 singleton pregnancies, only 51, so it's not a very large study if you think of 3 medication used. And they performed amniocentesis to rule out infection in many patients, and only 14 patients in the group received steroids. So that in the end, you get 19 patients that got mag sulfate, and 19 patients got the placebo, which was D5 Ringer's lactate, and 16 got terbutaline. The demographics, the characteristics of the patient was the same in all groups, in all 3 groups. They got 5 grams bolus of magnesium sulfate in 2 grams per hour, which was continued for 12 hours, or 48 hours if there was a rupture of the membranes. In terms of delivery delay, unfortunately, not much difference between all groups. Numbers are small again. 12 patients in the placebo group achieved a delay of 48 hours versus 10 in the magnesium sulfate group versus 19 in the terbutaline group. Birth weight was similar in all groups. There was no significant difference. The only thing that was of significance was there was a bit more infection in the terbutaline group compared to the placebo group, but all the other morbidity were the same in all groups. But when you look at so many factors, of course, something is going to come out significantly different. So conclusion of that study was that magnesium sulfate was acceptable in terms of maternal side effects profile, but there was no efficacy with prolonging the pregnancy, increasing the birth weight, and no change in the the neonatal mortality and morbidity. Cox in 1990 made another randomized controlled trial, compared magnesium sulfate and placebo. Their criteria to be in the study was regular contractions, dilatation between 1 and 4 centimeter, a gestational age between 24 and 34 weeks, and they only wanted patients with intact membranes. So a bigger study Still not incredibly high numbers. Nevertheless, they ended up with 76 patients on mag sulfate and 80 patients on saline, the placebo. It was a blinded trial. There were few twins, there were no crossovers, and they received a fairly high dose of magnesium sulfate. I don't know about other places, but in our institution, usually we give 2 grams an hour of magnesium sulfate. They got 3 grams per hour of magnesium sulfate, which is a fair dose. And so much that about 10% of patients had to be discontinued from the medication because of side effects. The characteristics of the patients were the same in each groups in terms of dilatation, gestational age, effacement, and dilatation. The results were again fairly disappointing. Not much difference. They had different cutoff at different gestational age. The only difference that they found is that a few more patients delivered between 33 and 35 weeks in the placebo group compared to magnesium sulfate. But in the overall outcomes of pregnancy and gestational age of delivery, there was no difference. 33 weeks was the mean gestational age at birth. And same thing for the delays achieved. No difference between placebo and magnesium sulfate. Increased stillbirth rate in magnesium sulfate group, 5 neonatal death versus 1 in the placebo, 1 infant death. But I think a few of them were due to anomalies. These are the reasons for the perinatal death. So conclusion, again, no efficacy with respect to pregnancy prolongation and no change in the neonatal mortality and morbidity. So magnesium sulfate is ineffective in those concentrations. Beta agonist, again, is the only FDA-approved drug in the States, but not available, Ritidrine, but still used readily. Terbutaline is used a lot in many places, even if there was some serious drawback in some articles showing that it makes actually no difference at all. There are a lot more side effects from the beta agonists than some of the medication. They are structurally related to adrenaline and noradrenaline. They are beta 2 receptors of the uterus, therefore causing, at least in theory, a smooth muscle relaxation of the uterus. They tend to be diabetogenic, and there are significant cardiopulmonary side effects such as tachycardia, pulmonary edema, arrhythmias, myocardial ischemia, and there's even been reported death, fetal and maternal, due to the use of beta agonist due to MIs. So it's something very serious. And this is this phenomenon called tachyphylaxis, where the uterus gets used to this medication, therefore respond less well to the beta agonist. The biggest trial was from Canada, involved 6 centers, and there were over 700 patients that were randomized to either Ritidrine or placebo between 25 and 35 weeks, and they measured the outcomes such as perinatal mortality, delivery delay, birth weight, and neonatal morbidity. The definition of preterm labor were more than 4 contractions per 20 minutes or 6 contractions per hour, or any uterine activity with rupture membranes, or any uterine activity and a cervix that was 50% effaced, or any uterine activity and a cervix that was at least 2 centimeters. So again, it was quite a heterogeneous group of patients. And they did see a difference in terms of delaying delivery by 24 and 48 hours. 20% of patients delivered within 24 hours in the placebo group versus 7.1% in the Ritidrine group. 48 hours, it was 35 versus 21%. So, but unfortunately, they didn't see any difference in terms of perinatal mortality. The overall perinatal mortality was 6.4% in the placebo group versus 6.1% in the Ritidrine group. So, this is the conclusion that they came with, is that there was no difference with respect to gestational age of delivery, birth weight, RDS, and neck, and there was an increase, not surprisingly, incidence of chest pain, arrhythmias in the Richardson group. But it also allowed some patients to be transported from one hospital to another, so there were some benefits also that we shouldn't forget. Terbutaline, many trials have been shown that there's no advantage of placebo, so I'm not going to talk about it very much. Maintenance tocolysis, I wouldn't even say it's controversial. I think it's not working at all. Pump, oral, however you want to give it. And there was a warning from the FDA in JAMA in 1998 against the use of terbutaline, which is a great drug that I use for external cephalic diversion, but never for premature labor. Let's talk about the NSAIDs now, the COX inhibitors. The COX inhibitors are interesting. They work at the level of prostaglandins and on the myometrial cells. They increase the intracellular calcium content and the number of gap junction. The one which is used the most is indomethacin, called in different countries Indocid or Indocin. It's been in use since the mid-80s. In the pathway of preterm labor or labor, it works at that level here in between the conversion of arachidonic acid and the prostaglandins. There have been a few placebo-controlled trials by Zuckerman, Niebel, and Panter showing some effect I'll present. And indomethacin has been compared to magnesium sulfate and ritodrine as well in several trials. And the trials conclude that indomethacin compared to placebo did decrease the risk of delivery prior to 34 weeks, as well as the risk of delivery prior to 37 weeks, and was at least as efficacious as magnesium sulfate and ritodrine. However, you have to keep in mind that in these studies the numbers were small, less than 100, and most of these trials were done prior to the widespread use of corticosteroids to enhance fetal lung maturity. The NSAIDs also have side effects. It increased the coagulation problems, increased bleeding time, decreased platelet functions. GI upset can cause fetal nephrotoxicity and bronchospasms as well. In terms of fetal side effects, it causes a constriction of the ductus, so it should never be used after 32 weeks. And because you often have a transient oligohydramnios, this is why you should never use after 34 weeks. It's usually reversible though. And it's been shown in some studies, not all studies, but that you have an increased incidence of necrotizing enterocolitis and intraventricular hemorrhages. The protocols that's been used most often is that you use a loading dose between 50 and 100 milligram rectal suppository and use it for 48 hours with an oral dose between 20 and 50 milligrams every 6 hours for 48 hours. No more than 72 hours, and I think it's important to verify pre and post amniotic fluid indices. Calcium channel blockers. The one we use the most is nifedipine. It decreases the intracellular calcium. Ultimately, this is what you want to cause to decrease uterine contraction. It has a very rapid onset of action, and it's also very simple to use. It's a simple pill. It's at least as efficacious as magnesium sulfate and ritodrine, and certainly has a much better side effect profile. Unfortunately, there's no, at least to my knowledge, any placebo-controlled trials comparing nifedipine to a placebo. Hypotension is a common side effect, not surprisingly, because it's antihypertensive medication. Otherwise, the side effects are infrequent. The dosages are between 20 and 40 milligrams loading dose PO. Then you use it between 10 and 20 milligrams PO every 4 to 6 hours. Again, like any tocolytics, I think our goal should be to achieve a delay of 48 hours to give steroids on board and not go beyond that. So in terms of preventing preterm delivery now, I'm going to briefly touch on it because my topic was really tocolysis. You have secondary prevention, which is recognizing patient with subclinical preterm labor. Tertiary prevention, which is decreasing the morbidity associated with preterm delivery. And the primary prevention really is identifying patients at risk of preterm delivery and intervene before the onset of preterm labor. So progesterone, I'm sure you've heard about in the most recent year, decreases the action of estrogen at the level of the uterus, increase the formation of progesterone receptors, and decrease the response to oxytocin. It can be given by suppository or intramuscular injection. There were at least there's many trials, but the two trials I'm going to talk about were the initial two trials, one done in Brazil involving 142 women who had a history of preterm delivery or uterine anomaly or cervical insufficiency. So they got 100 milligrams of progesterone daily or a placebo. And the results were pretty impressive in terms of patients undelivered. Patients who were exposed to progesterone tend to deliver later, tend to have less morbidity as well compared to the patient on the placebo. In terms of number of frequency per hour, also a significantly increased number of contractions in the patient in the placebo group versus the progesterone group. I don't know if you see the slide very well, but they significantly showed a decreased rate of delivery prior to 37 weeks and 34 weeks. So remember, this is not in the context of preterm labor, it's in the context of patients at risk of preterm labor. And they had less admissions in the progesterone group for preterm labor, and a lot more patients had a delay of 72 hours in delivery in the patient exposed to progesterone. So quite impressive. And in the New England was published in 2003, this big MEAS trial. I think it was an NIH-funded trial, essentially mimicking the same thing, where they had about 500 patients that were randomized to either receive an IM dose of progesterone or a placebo. It was a multi-center trial involving 19 centers. The characteristic of the women were the same in each groups, and the outcomes were quite impressive. Quite less patients delivered before 37 weeks in the group exposed to IM progesterone versus placebo. Decreased incidence of spontaneous preterm labor, decreased incidence of delivery prior to 35 weeks, prior to 32 weeks, decreased number of visits to the hospital, and decreased use of all these outcomes that essentially you aim for. And also, importantly, there was a decrease in the incidence of birth weight babies that were born less than 2.5 kilos. So quite an impressive prevention for preterm labor. So in conclusion, I think there's no clear proven benefit to give tocolytics in the acute setting of preterm labor over placebo, unfortunately. Always search for an underlying cause, because sometimes when you have preterm labor, it's a way of the body to tell you something is wrong and the baby is better outside than inside. And remember, there's always potentially harmful side effects that are attributable to the tocolytic itself. And there's no clear line tocolytic according to the American College of OBGYN. And in my opinion, and I think it's coming, at least for the use of tocolysis, magnesium sulfate should be abandoned. There's some data now suggesting that magnesium sulfate is helpful in preventing cerebral palsy, but that's a completely different story. We have no question that magnesium sulfate is helpful in preventing recurrent seizure in eclamptic patients, but in the context of stopping preterm labor, I think it has no role at all. I'll be welcome to answer any questions.
Creo que la idea es